Mr. Chairman, ladies and gentlemen, the trends in renal transplantation over the last 10 years have shifted significantly in the presence of an ever-expanding waiting list of patients, which is shy of 7,000 currently waiting a renal transplant. There's been a plateau in the number of living donor kidneys demonstrated by the light blue bars, and there's been a significant increase in the last decade in the number of donation after cardiac death kidneys, so-called DCD kidneys. Now, this is currently an underutilised resource, but it does have pitfalls. Following circulatory death, the kidney has to be harvested rapidly as the ongoing warm blood causes a significant ischemic insult in the absence of oxygen. Following harvest, it's then placed on ice and it undergoes a further episode of cold ischemic injury, and then the organ is transplanted and subjected to reperfusion injury. So you take what was previously a relatively normal functioning kidney, and these three tiers of damage lead to a reduction in renal blood flow, high intrarenal resistance, tissue edema, reduction in urine output, and it's all as a result of this complex inflammatory cascade, Ischaemia-reperfusion injury, which involves activation of immune cells, cytokine release, depletion of mitochondria and cellular swelling, which causes reactive oxygen species, which directly damage DNA, proteins, lipids, and you get cellular apoptosis and necrosis. And this has clinical sequelae. So patients who receive donation after cardiac death kidneys have higher rates of primary non-function, and this is a disaster for both patient and clinician as the kidney never works. They have high rates of delayed graft function, up to 80%. This is when the kidney doesn't work straight away and the patient requires a period of dialysis. This is an independent risk factor for acute episodes of rejection. It prolongs hospital stay, and overall the graft survival is worsened. Long has been sought an agent to ameliorate or attenuate this cascade, and hydrogen sulfide has been much studied of late. It's an endogenously produced gas, which is classified alongside carbon monoxide and nitric oxide. It's lipophilic and freely permeates the cell membrane, acting on DNA and mitochondria, and it's been discovered in many biological tissues. It has anti-inflammatory properties, antiplatelet properties, and it's mitochondrial protective as well as a vasodilator. So the aim of our project was to assess the effect of hydrogen sulfide in a large animal model of renal warm ischemia. We designed a blinded placebo-controlled trial which randomized large white pigs into control or sulfide treatment following standard home office protocols of care. There were 6 animals randomized to each group using a sealed envelope technique, and this was done by staff independent of the study, so veterinarians and surgical staff were all blinded. 2 animals were also allocated to a control group, and hydrogen sulfide was given as a sodium sulfide salt, which is a known sulfide donor, and was given at 100 micrograms per kilogram bolus, and then a continuous infusion of 1 milligram per kilogram. The methodology is shown schematically here. So the control group and the sulfide group underwent midline laparotomy following general anesthesia. The left renal pedicle was exposed and underwent cross-clamping for 60 minutes. 10 minutes prior to release of the cross-clamp, either the sulfide therapy or the saline control began, and this was a continuous intravenous infusion. 10 minutes after this, so following 60 minutes of renal ischemia, the clamp was removed and a right nephrectomy was performed. So the animals were left with a single damaged functioning kidney. The sham animals underwent an identical procedure, except there was no cross-clamping of the left renal pedicle. Animals were recovered for 7 days, and renal biopsy samples were taken on entry to the peritoneal cavity, 30 minutes following reperfusion, and an autopsy, and blood and serum were collected throughout the study period. The demographics show that there was no significant difference between weight of animals, between operative duration. All animals survived, and there were no biochemical or hemodynamic differences throughout, as high-dose sulfide is known to have a metabolic effect, and this is demonstrated by the intraoperative gases. The results were really quite startling. We used serum creatinine as a measure of renal function, which, as you all know, is the most widely used measure in clinical practice. And the graph demonstrates the sham animals, as expected, had barely any change in their renal function. And the top line, which highlights the control animals, had a dramatically increased creatinine in comparison to the sulfide-treated animals. This reached statistical significance from day 1 through to day 5. Area under the curve creatinine was significantly reduced in sulfide-treated animals, as was time to creatinine back to 250 micromoles per litre. Serum urea demonstrated a similar trend, and really I've illustrated this just to show that it runs in parallel with creatinine. It wasn't a hydration-related issue. This was acute kidney injury. Again, area under the curve was significantly different in urea in the sulfide-treated animals. We looked at the protein-creatinine ratio in the urine as a marker of glomerular and tubular function. So protein was measured from urine samples at 30 minutes, day 1, 3 and 5, and again it demonstrated a significant reduction in sulfide-treated animals, illustrating protection of the tubules. As an anti-inflammatory agent, we looked initially at tumour necrosis factor alpha, which is a well-validated marker of early injury and ischemia-reperfusion, and this, although reached statistical significance at 6 hours, the trend was one of reduced levels, but there was no statistical significance beyond that. Myeloperoxidase was used as a marker of neutrophil infiltration. Renal biopsy samples were stained and cells were counted, and this also demonstrated significantly reduced levels in the sulfide-treated animals early on. And the slides just illustrate these. Urinary NGAL is a novel biomarker. It's a protein that's excreted by damaged tubules in the kidney, and it's measured in the urine. And in the same way as the anti-inflammatory markers, it demonstrated reduced levels in the sulfide-treated animals, but again, this didn't reach statistical significance. And so, Mr. Chairman, ladies and gentlemen, in conclusion, a model of renal warm ischemia in large animals has demonstrated that hydrogen sulfide improves renal function, has some way of reducing inflammation, and has protection over the tubules. And we feel this provides an excellent platform from which we can move sulfide into an auto-transplant model and potential clinical trials. And indeed, there is a company in the United States currently who are doing phase 1 trials on sulfide therapy. Thank you very much.